burns and trauma. Here's the objectives. So when we talk about trauma, there are trauma assessments that are done. Okay, so you have airway, cervical spine is always going to be at the top of the assessments. Breathing, then circulation, then neuro, then exposure. Right? So basically what's going to kill the patient the fastest, that is what we're going to look at. Poisoning. Was it an ingestion? Was it an overdose? If it's an overdose, if it was accidental or intentional, it does not matter. Was it medications? Was it other types of drugs? A toxic agent? An exposure at work? Details on these matter. Was it an air exposure? Was it a liquid exposure? We're going to talk about burns later in here. If you're going to work in EMS, Poison Control Center is a number you are going to want to have handy. Treatments. We always go to respiratory first. How's the patient's breathing? How's the patient's airway? A lot of times we're going to be giving high boluses of IV fluids to flush out whatever could be in the body. GI-wise, we're going to use active charcoal. Patients can swallow active charcoal. A lot of times, though, we do have to put an NG tube down to get it into the GI tract as fast as possible. If the patient's having seizures, we typically use a diazepam, Ativan, something like that. If there's a reversal agent, Poison Control will let you know what that is, and then we can get that on board. Emergency Medical Treatment and Labor Act. This is still very much an act that is in place today. What does this mean for anybody in the U.S.? That we care for patients in the hospital regardless of any factor. If they can pay, their immigration status, it doesn't matter. As an ER nurse, I don't care. I'm just going to take care of my patient. We have to stabilize the patient. Cardiac assessment's always going to be a very pertinent thing when it comes to the Emergency Medical Treatment Act. So if they have any type of difficulty breathing, any type of chest pain, we're going to make sure we're doing a cardiac assessment. Individuals that are pregnant, we always have to make sure we are doing a full OB assessment. A lot of times someone that's pregnant, we will actually send them up to the OB unit. ER nurses are not trained to do an OB assessment, or sometimes an OB nurse will come down if the patient is more in the first trimester. So emergency preparedness. If you're going to go into EMS, you're going to be very familiar with the Casualty Act. So there are 4 different categories of the Casualty Act. Red is emergent. These are the patients that are going to be seen first. They could be having difficulty breathing. They could have an amputation, whether it be a digit or a limb. Yellow, they can wait a short time. So a couple hours out, they can wait. This could be broken bones, as long as they're able to breathe on their own. This could be a mild burn or a significant burn. Green is not urgent. These are patients that are essentially walking and talking. They might have a minor burn, a minor laceration, a minor bone fracture. These are not patients that we're going to spend a whole lot of time with. And then unfortunately, we have the black tags. These are patients that have no pulse. When it comes to a trauma setting where we are triaging patients, if the patient has no pulse, we do not try to resuscitate them. It's going to take too many staff members. It's going to take too many resources. Hospital setting is a little different. So if we have mass casualties coming into the hospital, these have already been tagged. So again, we go to red first. Reds are the patient difficulty breathing, cardiac dysrhythmias, amputations. If their blood pressure is dropping, if their heart rate is going up, they could be going into a shock, and they would also be a red patient. On to burns. So patho of burns. You can read patho of burns. Types of burns. We have dry heat, we have moist heat, contact, which is usually an object hit the patient's skin, or grease or oil. Chemical, both alkalotic and acidotic. I've seen chemical burns for industrial cleaners, fertilizers, electrical conduit. When we have a patient that has a burn from an electrical conduit, so basically if they were electrocuted, always we must watch for dysrhythmias. All right, we use electricity to bring the heart back. Electricity can do some issues with the heart. It may not be a dysrhythmia that is going to kill the patient, but we still want to be very, very perceptive on cardiac issues. Flash would be an exposure, as in a explosion. Radiation, long-term exposure to X-ray. Even sunburns, so type 2, type 3 sunburns. And then smoke inhalation, which we're going to talk about more in a little bit. So your type of burns, you have your first degree burns. These are the superficial ones. These are ones that patients typically can care for at home without an issue. And then you have your second degree burns. Second degree burns, these are like the partial thickness burns. They're red, they're moistened, they are blistered. And then the third degree burn, this is the eschar. Eschar is very concerning, especially if it's near the face, the neck, the chest, because we're going to be really, really concerned about airway issues. So superficial thickness. This is the least damage. These are the ones that we typically see at home that do heal within the week. There might be some discolorization or scarring, but it's usually very, very mild and not much of an issue. Then we go to partial thickness. Partial thickness is that reddened, burn, it's blistering, it's weeping. These are the patients where we're going to have those chucks underneath the limb or the part because it's just going to constantly be oozing out fluid from all the blistering. Full thickness, this is the eschar we were talking about, where it's going almost completely down to the bone. The skin here does not regrow. So this would be a patient that would need grafting later, and that's a much later down everywhere. There's no blistering, but the limb will be super edematous. The only good part about this is there's very minimal sensation for the patient, and this could take months and months to heal. So early treatment, especially when we talk about the more severe burns, these patients are actually going to be put on neutropenic precautions just because they have lost the natural defense that the body has to keep infection away. So they're going to be under neutropenic precautions. Again, airway is going to be the most important thing that we're looking at. Circulatory support, fluid replacement is going to be huge. We're going to talk about Parkland formula. Lactated ringers are typically the fluid replacement that is utilized. Maintain body temperature. We're worried about both hypothermia and we're worried about fevers for infection. Respiratory issues. As soon as we can, we're going to get O2 on the patient. Doesn't matter what type of burn it is. We're definitely going to be concerned about smoke inhalation, especially for house fires. So if it's a house fire issue, we're going to be watching for smoke inhalation signs. So low pulse ox, coughing a lot, difficulty breathing. Sometimes they have stridor. Then we're going to assess the burns, if there's any, Then we're going to assess any wounds that are opened, again, if there's any, and then we'll worry about any type of history with the patient later. Priority, history is not a priority for the patient with this right now. Like I said earlier, we are very concerned about that eschar with patients, especially like on this picture, it's around his face, it's around his neck. We are really concerned about difficulty breathing, and sometimes these patients will be put in medically induced coma and we will intubate them while we assist the body in healing. Cardiovascular changes, again, if the patient was burned or shocked in any way, we are really concerned about dysrhythmias. So we're going to put them on telemetry right away. We're going to get a 12 lead for a baseline, and then we're going to do all our normal protocols. So hypovolemic shock, we're going to be doing vital signs a lot. So we're going to be watching that heart rate, the respiration rate, and the blood pressure. We're also going to be watching for a fluid shift. So if all of a sudden there's third spacing going on in their intercellular tissues, typically that happens within the first day, if it's going to happen. GI and GU changes, we're essentially really looking at kidney function. We're looking at fluid and electrolyte replacement is going to be a high priority. So we're going to be getting lab panels, get a complete metabolic panel. We're going to be weighing the patient. We're putting a Foley catheter in the patient so we can get good output. Skin stages. This is the rule of 9, and we will talk about this more in person in class when it comes to the Parkland formula. So IV hydration, again, this is the Parkland formula. We'll talk about that next week in class. Management of burns, especially in the acute phase. Fluid replacement, electrolyte replacement is going to be a very high priority. This is going to be electrolyte. I'm sorry, not electrolyte. Lactated ringers are going to be the fluid of choice when we're giving fluid to the patient. We're also going to be watching for albumin levels. A lot of times we're giving the patient albumin from all that skin breakdown. So getting an albumin level every day is going to be a great measurement tool to see if the treatment is working along with the vital signs and urine output. So management of patients with eschar. So there's a couple different types of surgeries that can be done after healing has happened. So we can do complete skin grafts, we can do fasciotomies. These are going to be leaving a lot of scarring. The patient may be very self-conscious about this, which is understandable. When we do a skin graft, so especially like on a limb, like a foot or hand or arm or leg, once the skin graft is on, we're going to immobilize that. So a lot of times the skin isn't touching like a sheet or a bed or a pillow. We're gonna raise it and we're gonna try to immobilize it and definitely get it elevated with the heart so we have good blood return. When this is going on, we're going to be watching the pulse, the urine, and the blood pressure are going to be assessed. You got to make sure that the kidneys are not compromised. Different treatments that's used, we use something called silver nitrate. It reduces fluid evaporation, but that won't penetrate eschar if there is any. Okay. Something called the acetate there, the nifednyl acetate, that will penetrate eschar. So some docs will use it to get through the eschar to good tissue. That can be a painful process. So we have to make sure that we're well medicating the patient. Like I said, we do debridement both mechanically. Usually that patient's going to be sedated or in the OR and intubated for mechanical. Hydrotherapy can be used, not for everybody, but it is a possibility. So different dressing changes, again, with skin grafts, that's going to be something that we usually typically get from another area of the patient. We can do auto skin grafts from donors, but that is not as common. So some complications we can get during the rehabilitation phase of management, paralytic ileus, there can be some GI issues. Watch the kidneys, this could cause an acute kidney injury, and they can get a lot of different stress aspects. So they can get stress ulcers, bleeding ulcers. There's a lot of issues that go along with that.